two most common causes, but can be caused by any injury or disease that initiates massive systemic inflammation. This can include trauma, burns, acute respiratory disorder, major surgery, circulatory shock, necrotic tissue, disseminated intravascular coagulation or DIC, acute renal failure, and acute pancreatitis. Greatest risk is older adults and those with significant tissue injury or pre-existing disease, and those in whom resuscitation from the initiating illness or injury has been delayed or inadequate. Mortality rate is 54% when 2 organ systems are affected, and mortality rate increases to 100% with the failure of 5 systems. Primary MODS, or multi-organ dysfunction syndrome, include injury is directly associated with a specific insult, leading to hypoperfusion. Presumably, neutrophils and macrophages are primed by cytokines, and any second insult, such as an additional tissue injury, infection, or organ ischemia, activate the primed cells to produce an exaggerated response of secondary multi-organ dysfunction. On to secondary MODS, which is an excessive inflammatory reaction. This occurs during the latent period after the initial injury in organs that are distant from the original injury site. It can be caused by the host response to a second insult rather than a direct result of the primary injury. Second insult is mild, but an immense disproportionate response is produced because of the previous priming of leukocytes. This can lead to a barrage of mediators, particularly the cytokine, tumor necrosis, and interleukin being released. The interaction of injured organs leads to a self-perpetuating inflammation. So MODS involves several responses. Stress response occurs, complement, coagulation, and kinin proteins are released. This causes changes in the vascular endothelium, and numerous inflammatory processes are mediated by substances. This leads to release from activated neutrophils and macrophages. In turn, proteases from the neutrophils directly damage the endothelium and neighboring cells, allowing an increased permeability. The activated neutrophils accumulate in the organs, and they play a key role in the pathogenesis of MODS. Maldistribution of blood flow. There's an uneven distribution to various organs and between the large vessels and capillary beds of the body. Adhered neutrophils, they migrate through the endothelium and aggregate in the areas of damaged tissue, amplifying the inflammation process. Activated endothelial cells increase the production and release of nitric oxide, which is a potent vasodilator, and that in turn causes increased vasodilation, increased vasopermeability, and selective vasoconstriction. Hypermetabolism occurs where an endocrine response becomes excessive, causing increases in circulatory catecholamines. It also is mediated by the action of TNF and interleukins and causes the alteration in carbohydrate, fat, and lipid metabolism. This in turn becomes detrimental, placing enormous demands on the entire body, particularly the heart and other body systems. So there's a 4 major plasma cascade that's activated. Complement, kallikrein-kinin, coagulation, and fibrinolytics. And the tendency toward clotting is greater, resulting in a net pro-coagulative state. This leads to myocardial depression, where there's an effect of the myocardial depressant factor on cardiac contractility, and hypoxia in the myocardium. The supply-dependent oxygen consumption is an imbalance in oxygen supply and demand, and the reserve has been exhausted, and the amount of oxygen consumed becomes dependent on the amount of the circulation and what it's able to deliver. If the amount is inadequate, the tissues become hypoxic, And then there's a reperfusion injury where organ damage occurs with the reestablishment of blood flow after a period of ischemia, and oxygen radicals attack the already damaged tissues. So the clinical manifestations that you'll see with multi-organ dysfunction syndrome include encephalopathy, characterized by mental status changes ranging from confusion to a deep coma that can occur at any time. Sequence of these clinical manifestations can rapidly evolve, or it can evolve over weeks. This is just a breakdown. At approximately 24 hours, you may have a low-grade fever, tachycardia, tachypnea, dyspnea, altered mental status, and general hyperdynamic and hypermetabolic state. At just 24 to 72 hours, you'll have the beginning of lung failure with a possible appearance of ARDS. Between days 7 and 10, the development of hepatic, intestinal, and renal failure. By day 14 to 21, an increased severity of renal failure and liver failure, also possible occurrence of death, and later that would lead to hematologic failure and myocardial failure. Prevention is essential, and eliminating or controlling the initial source of stress is imperative. You want to avoid the second insult if at all possible and remove any potential of infection. Treatment includes providing oxygen and nutrition to failing organs, administering antibiotics, and restoring the intravascular volume. If the respiratory system is affected, of course, you will need mechanical ventilation, low tidal volumes and high oxygen concentrations, and the use of PEEP. With the GI system, you may in turn need enteral feedings or hyperalimentation, tight glucose control with plan of glucose between 80 to 110, and then calories are needed for a hypermetabolic state. With the renal system, it may lead to dialysis or continuous hemofiltration for fluid and electrolyte balance. And in the cardiovascular system, you're looking at inotropic drugs or vasopressors, and steroids are somewhat controversial. So here's a question. Endothelial cell dysfunction and mediator response in multi-organ dysfunction syndrome produces what? A net procoagulant state, vasoconstriction, a reduction in oxygen-free radicals, or decreased proteases.